Everyone. Today we are excited to introduce Dr. Anne Geiger, a proud native of rural West Virginia. Dr. Geiger earned a BA in biology from Harvard Radcliffe College and an MPH and PhD in epidemiologic science from the University of Michigan. She's the scientific director of cancer care delivery research in the National Cancer Institute Community Oncology Research Program. She's previously served in several other leadership roles in the NCI Healthcare Delivery Research Program and has been involved in multiple national initiatives, including currently serving as the Quality of Life Co-Chair for the NCI COVID-19 in Cancer Patients Study. Before joining NCI, Dr. Geiger conducted research in both academic at Wake Forest School of Medicine and delivery system settings at Kaiser Permanente in Southern California. She has co-authored over 120 publications spanning the cancer continuum from screening to survivorship with a strong interest in care disparities. So join me in welcoming Dr. Geiger.
Hi, everybody. It's good to be here. What I'm going to do today is tell you a story more than anything. I'm going to tell you a story about how a federal agency tackles a longstanding challenge. And hopefully along the way, I'll share some scientific information and then at the end, we'll have some time to talk. So Jennifer, next slide, please. I'm a little bit of a history buff, and so I wanted to start today by sharing with you that it is the 50th anniversary of the National Cancer Act. And that is something that President Nixon signed in 1971 that really altered the course of cancer research in the United States. Among the other things it did is establish what we now know as the NCI Designated Cancer Center program. And those are really giant engines of cancer research in this country and have really made a huge difference. It also is believed to have really increased the funding we get for cancer because we're allowed to send a budget directly to the president rather than through NIH. So that gives us a little more visibility at that level. And lastly, I probably wouldn't be here today without the Cancer Act because it called for cancer control research, which had not previously been considered the realm of NCI. NCI was very focused on treatment at that time. So our director has really asked us to make this a time to celebrate what we've accomplished and think about what we have left to do. Next slide, please. So an obvious question then becomes, how are we doing? And depending on who you talk to, we're doing great or we're not doing so well. I like to think we're doing pretty well. We've decreased cancer death rates, and that's in the face of an aging population that both is going to have more cancer and probably die more quickly from it. You'll see that blip there. That is the HIV cancer-related blip in the 80s and 90s. So sometimes you'll see this figure where they've pulled out the HIV related cancer deaths, and that graph will obviously look a little different. For those of you who are history buffs, or public health buffs, you'll note that tobacco is probably the biggest driver. Tobacco cessation is probably the biggest driver of the drops in cancer rates. Next slide, please. Another way to ask how we're doing, and by this metric, I think it's clear that we're doing better, is a dramatic improvement in 5-year survival. And so, in 1975, you had about a 50% chance of surviving cancer 5 years, and now it's up to 70%. And for some cancers, it's above 90 or approaching 90. And so really some dramatic progress, including with childhood cancer, which has been obviously is devastating to families. Now, I will note this is a little bit dated graph. I couldn't find anything more recent, but it does look like it's leveling off a little bit. So it'll be interesting to see what happens there. Next slide, please. So as I mentioned a minute ago, the Cancer Act really put cancer control on the map for NCI. And our division was not formed at that time, but it was formed probably about 20 years ago. And we are the focal point for cancer control at the National Cancer Institute. And we have always had a very strong health disparities focus. And so I've I've put our quote there, really spans the scope of anything in cancer control and all the different factors that come into play. And I'll note that we recently did some tabulations and realized that we are the largest funder of disparities research at the National Institutes of Health. What we're investing in disparities exceeds the National Institute for Minority Health and Disparities. So we're very proud of that part of our portfolio. Next slide, please. So what about the rural piece? The rural piece is not something that has been a focus of disparities. I went to NCI in 2013, and you really didn't hear much about rural health at that time. I actually had a rural health grant that, I would say now was doing pretty crude work at the time, but was one of the few that had been funded by NCI. What's interesting is during the Trump administration, we started to see some real interest in this area. And you'll see that President Trump signed an executive order in August of 2020 calling for activities in rural health generally, and then also in rural cancer. And you'll see there were two reports that really spurred action in this area. And of course, action before the reports and then action after the reports. So it's always good for us, for what we want to do, to have the administration issuing executive orders like this. Next slide, please. So obviously, probably many of you know that President Biden and Dr. Jill Biden had a son, Beau Biden, who died of cancer. And so they are clearly very engaged in cancer. And you'll probably recall during President Obama's administration, the cancer moonshot was started. And the notion of the moonshot was to accomplish in 5 years what it would take 10 years otherwise to accomplish. And a huge amount of money was poured into special initiatives at NCI. And I'm going to come back to that because some of that money did come to us. On his first day in office, President Biden signed an executive order about racial equity and support for underserved communities. And you can see a quote there, but he signaled very early on that this was going to be something that mattered a lot to this administration. And I'll also say that we at NCI are both excited and I think a little intimidated by the level of attention we've gotten so far from the Biden administration. Within the first 3 weeks of that administration, we had been visited by Dr. Biden for a 2-hour visit, virtual visit. And Dr. Biden had also gone to the Virginia Commonwealth University Cancer Center, Massey Cancer Center, and met in person with people there, specifically talking about community engaged research. And in addition to that, the vice president had come to NIH to get her COVID shot and had given a presentation there about how much she valued NIH and expected big things of us. This all happened in 3 weeks. So we're excited, but I think we're going to have some attention paid to us. And as you know, the president is talking about starting a HARPA, a different sort of agency that would try to move health research, take away some of the constraints that we face. So a lot of energy in this area, which is terrific. Next slide, please. So although we talk about progress in cancer research, it's not equal. And I'm sure this doesn't surprise any of you. The mortality rates appear to be falling for all racial and ethnic groups. Although American Indians and Native Alaskans, it's a little less clear because the sample sizes make it a little harder to tell. But even though everyone is experiencing improvements in outcomes, you can still see there's some dramatic disparities there. And I will tell you, some work I've been involved in suggests that these disparities, after narrowing for many years, may have started to increase again because of the economic problems in the 2008-2009 time period. And I have to think COVID will not reverse that trend and may even make it worse. So we're going to be watching these obviously very closely. Also, the emerging treatments in cancer are quite expensive. And so that may differentially impact some of these populations. Next slide, please. So this is the rural part. I thought this was a really interesting picture of the United States, and it shows the difference in the colorectal cancer mortality rate between the early 80s and a more recent period. And for you guys in New England, you're doing really fantastic. For the folks in the Southeast, not so good. And for my home state, not so good. And so, you know, this map really drives home we have geographic disparities in the extent to which advances in cancer have helped people in different communities. And obviously the South is a fair amount of rural areas in the highlighted states. Next slide, please. So this is a map that the National Health Statistics folks have put together, and it just highlights, once again, we could lay these maps on top of one another, we'd see the same places lighting up, that there's a higher overall cancer incidence and mortality in rural areas. And I think what's particularly striking for those of us in public health is that we see this increase in cervical cancer, colorectal cancer, breast cancer. I don't know why I don't have breast cancer on there. Lung, melanoma, oral pharyngeal. These are all cancers that we can prevent or screen for. And so it's really that there should not be these kinds of disparities. We should be able to do better, in particular with these cancers. Next slide, please. Now, of course, everybody wants to talk about rural, but you can't talk about rural without talking about other things that synergistically create even more challenges. And one of those is, of course, racial and ethnic minorities. And the Latinx population is basically exploding in rural communities in terms of proportion. It's growing at a rate of about 2% a year, and that has been going on for about a decade. So you see some real challenges in that regard as well. And you can also see similar shifts with American Indians. And so that's something when we talk about rural, we have to also take account of. Next slide. This is some recent work that has been done by members of our group, which is around persistent poverty. And places that experience persistent poverty are have people more likely to die from cancer. Again, not surprising, but it's over and above what places that are considered current poverty-stricken experience. And I will also note, I'm not showing this, but there is research that, again, if we laid these maps on top of each other, oncology care is much less available in counties with persistent poverty. So again, you see West Virginia lit up a little bit there. That's one of my home county lit up. It just makes everything worse. So we really have, and I will just say, I made a note to myself here. I've traveled to Indonesia. I've traveled to Belize after a hurricane. I've been all over the world, and you know, whenever you take a tour, they always take you someplace that's poor. And I almost always say, yes, this is devastating. And in some ways, it's not as bad as what you see in rural West Virginia in the United States. Really a problem, the poverty. So next slide. I'm going to stop preaching. I think this is my last preachy slide. This just shows you the effects of poverty and race, ethnicity, and non-metro together. And so you can see that poverty rates in Blacks and American Indians in rural areas is a third, which is dramatically higher than white. So, you know, again, just the challenges. Next slide, please. So this is a slide I always hesitate to present, and I hesitate because of my own personal experience of what I call the everyone is poor and uneducated phenomena. I will tell you, it's very interesting to tell people you're from West Virginia and tell them you went to Harvard. They often look at you like, how is that possible? You know, so these are some of the challenges that people think about with rural environments. I certainly agree with some or maybe even most of them, but I think it's it simplifies things in a way that I'm not quite sure is right. And I'm not quite sure we really have a handle on which of these types of challenges plays out in which environments. And I'm happy to say that my colleagues who created this slide has finally started to add some strengths of rural environments. And so, you know, social support, resilience, the role of churches where I grew up, there are benefits in rural environments as well. Knowing your elected officials, living next door to your elected officials, you know, going to church with them, there are things that I think we can leverage, and I think people are increasingly in the research realm understanding that it is not all grim in rural settings. Next slide, please. So what are we at NCI doing about all of this? And so this slide really illustrates what we've done for the past 5 years or so in other than funding areas. And this is something I like to remind people, NCI does a lot of things that aren't giving away money. And this is what I call our thought leadership and convening power in action. And so you'll see a number of publications in the journal Cancer Epidemiology, Biomarkers and Prevention that were really designed to call attention to need for research in this area, talk about a vision for that research, direct the research community toward issues that we've identified as important. And so that is something you'll see NCI staff doing when there's a new interest area. And then you'll also see some workshops and some meetings. I tell people one of the fun things for me about being at NCI is when I call, people answer the phone and they say yes. 10 years ago when I was at Wake Forest, that didn't happen. So we're really able to bring people together and have very effective exchanges of information, brainstorming, and that sort of thing. So we've used both of these powers in the context of rural cancer the past 5 years. Next slide, please. Now, these are some of our funding initiatives in rural cancer, and you'll see we've done quite a bit. Every one of those things across the top there, those 5 initiatives, take 5 to 10 people several years to make happen, to develop and get through all the approval processes and accept the grants and get them reviewed, on and on and on. So this is actually quite a lot of work. And you'll notice on the left-hand side there that we have what we call the cancer control continuum. And I'm actually going to pause for a minute and talk about that because it's something that not everyone is familiar with. So next slide, please. The cancer control continuum is really the way that we think about cancer in our larger group. And our belief is we have to be working in all of these areas in order to impact cancer incidence and death and other burdens of cancer on families and patients. And so, you know, there's etiology, more typical epidemiology. There are prevention activities. I'm going to talk about those in a little bit. There's screening and detection, diagnosis. Our group's a little less involved in diagnosis and treatment. We don't actually develop diagnostic procedures or test them, and the same with treatment, but we are interested in making sure people get the best quality care that they can. And then there's survivorship and end of life care. And you'll see the cross-cutting areas. We really see the need to coordinate activities across all of these areas in order to really address the cancer problem. Next slide, please. Oh, back up. I just called out these 2 areas. These are areas where I think our work really touches on primary care. And so I'm going to try and draw that out a little more through my presentation. Next slide, please. Okay, so this is back to the slide that I showed before of our funding activities. And you'll see we've really tried to touch on all the areas, but you'll also see there's been a lot of focus on diagnosis, treatment, and survivorship. And that's partly because the subgroup I'm part of has been very active in this area. I think the hospital closures, the consolidation of oncology practices, The aging of the population, aging of the workforce have really created for us an acute sense of need to address some of these issues in cancer care delivery. So I'm going to just work my way through these funding initiatives and tell you a little bit about the thinking behind them and what we hope that they will accomplish. And hopefully that'll tell you a little bit of a story and give you some insight into how we're tackling this. Next slide, please. So the first major capacity initiative is something that I'm responsible for, actually, primarily. At least a piece of it, I should say. So this is the NCI Community Oncology Research Program. Some of you may have heard of the CCOP program, Community College Community Oncology Program. This is something that was started in the 80s. It was actually a spinoff of the Cancer Center initiatives that came out of the National Cancer Act. It was revamped in 2014 rather, and made very clear that the goal was to bring cancer research to people in their communities. And so it really, in all honesty, has two goals. One is to bring treatment trials to people in their community. The other is to increase accrual to treatment trials. Without this network, treatment trials at NCI would not get done in a remotely timely fashion. This group contributes a third to half of the patients that go on treatment trials. So it's really very important, both for the community and for the advancement of science. And so this is a very large network. There are 7 research bases that coordinate the research. They're coordinating centers, but with a lot of academic responsibilities as well. They're really the hubs for what we do. And then we have 32 community sites and 14 minority and underserved sites. Those minority and underserved sites have to have 30% of their catchment area either in a minority or racial ethnic group or rural. And I'll come back to that in just a second. And when we look at this, we see over 1,000 basically settings, I'll call them, where oncology care is delivered. And these are primarily medical oncology practices. Have some radiation oncology, some surgical oncology, a little smidge of primary care, but very much dominated by medical oncology. Next slide, please. So when this program was redone in 2014, we also introduced cancer care delivery research into the mix. And this is the part that I'm responsible for. And you're going to see a couple themes emerging here that you're going to see throughout the rest of my presentation. And we were really interested in having a laboratory, so to speak, of places where people could study cancer care. Historically, if somebody wants to do a cancer care delivery study in the community, they have to go out and recruit community practices and build a network, and it's expensive and time consuming. And so our hope was that we could form a network and then have multiple different investigators use that network. And I think we've been somewhat successful, but we also really wanted to put our kind of research on the map for these organizations and for NCI at large, frankly. And so I think this has been the first couple of years were quite challenging. No one really understood what we were trying to do. Sometimes we didn't understand what we were trying to do, but I think we've made real progress. And this was included in the renewal in 2018. And so I think this has been very interesting and very helpful. And we see a growing number of ideas coming in that have a rural angle, so to speak. So next slide. So one of the big challenges for us in NCORE has been identifying the rural practices. We don't query, we don't have criteria that we can query sites. When you ask people if they think they're rural versus the technical classifications, you get different answers. So we have had a scholar, NCI Academy Health scholar from the University of Cancer, Dr. Shelley Ellis, work with us for about 18 months using some of the common algorithms that people use to identify rural settings. And you'll see the 4 here, HRSA, FAR, RUC, and RUCA, that she has tested. And I I put this slide up not to call attention to the process, but to remind all of us that this is not magic. She spent an enormous amount of time manually adjusting addresses and correcting them. And that's what that last column shows you, is the extent to which she had to tackle that. Next slide, please. So this is basically the upshot of her work. And as those of you who work with these data won't be surprised to learn, when you use these 4 categorizations, you get 4 different answers. Now, the frontier and remote answer makes sense. Those are very, very rural, very distant places. And so that made sense to us. But the other 3 codes give somewhat different answers and different sample sizes. And so we're in the process now of trying to understand which coding algorithm is best for which kind of study. But I will tell you, even the HRSA algorithm, it's very interesting. We had a study that used HRSA to identify eligible practices, and somebody from a practice walked up to me and said it was rural days celebration when I left today to come here to this meeting, and you guys don't think of my practice as rural. So we still, are struggling with this a little bit. Next slide, please. Now, the good news is if you use HRSA codes, about 17% of our practices would be considered to be in rural settings. So we're very pleased about this. We just weren't sure. And so it was very nice to know that's a healthy percentage that reflects the percentage of people that live in rural settings. And of our 40 odd funded sites, 3/4 of them have a practice in a rural setting. So there's a tremendous amount of potential here. And when you look at this map, you'll see the orange places are the rural practices. And you will see, again, we do not have equitable coverage of the United States. You'll see my, again, native West Virginia is completely empty. You'll see Texas, Oklahoma, places in the Southwest that have few or no rural practices, but there are rural settings there. And you'll see in the upper Midwest, we have some coverage, but again, huge swaths that are not covered by our network. And so that is something we are always trying to address. You'll also notice that New England is pretty empty, but I have good news about that. Next slide, please. So that map is of our first round of funding. In our second round of funding that happened in 2018, we added for the first time a site focused on rural populations, and that's at the University of Kansas. So that's very exciting for us. And Maine Health Cancer Care Network also was funded, and we now have coverage in the New England area. So we are very pleased about both of those additions. So this is really a huge capacity building effort, not just to build a network of practices, but to build a whole type of research focused on care delivery. Next slide, please. So then I guess the last question you might ask yourselves, certainly I get asked, is, well, you've got all these rural practices. Do they actually put anybody on studies? And the answer is about half of them do. And frankly, if we looked at our 1,000 practices entirely in the network, only about 1/3 of them put people on trials. So the rural practices are doing very well, or rather on our cancer care delivery trials. 1/4 of them aren't appearing to participate at all in these kinds of studies. And the remaining about 1/4 are having problems that are beyond our control. They're dropping out of the network, they're closing, really things beyond our control. And I will say some of the challenges we hear about from the non-accruers are a lack of physician interest in the types of studies that are being offered. Physicians have to complete some training to participate in studies, 8 hours or so of training. Many of you will be familiar with human subjects training as part of it. Good clinical practice for trials is part of it. And we find physicians just saying, I'm not willing to do that. And then there's staffing issues and infrastructure issues. We have a research associate in Montana who's very interested in doing these kinds of studies, but her clinics are several hundred miles apart from one another, and it makes it very challenging. She actually rotates through them, and it's just really challenging. So that is something that has a lot to do with how studies are designed as well, whether they're easier or harder to do at a distance. Next slide, please. So this is also a capacity building activity that also then starts to bleed over into science. We will often give NCI designated cancer centers some additional funds with very targeted requirements. And so more broadly over the past few years, we've changed some of the requirements for cancer centers, and they're now required to be much more engaged in their communities than they ever have been. And these supplements were to specifically give them funds to engage in the rural communities that are around the cancer centers or that they're somehow affiliated with. And so I put an example here of how the University of Texas Southwestern Simmons Comprehensive Cancer Center is trying to get some work started on the Texas-Mexico border and do screening for cervical cancer and liver cancer there. Another example I'm very familiar with is Ohio State University has an extensive collaboration with practices and communities throughout West Virginia trying to promote cancer screening in West Virginia. So there are a number of activities that have been initiated with this funding. And the hope, of course, is that these are permanent relationships that result in applications for specific research funding. Next slide, please. So we have two major moonshot initiatives that have engaged rural type questions. One of them is ACCESS, which is Accelerating Colorectal Cancer Screening and Follow-Up through Implementation Science. And 4 of the 5 grantees have a rural angle of some sort. Appalachia, I actually just mentioned part of what they're doing, really working in the community to try to increase screening. University of North Carolina is actually taking a Kaiser Permanente managed care approach to the state of North Carolina and doing centralized mailing of fit tests and then hooking people up with local practices if they test positive. Oregon Health Sciences is doing something similar to that. And apologies, I forget what they're doing in California, but these are all tailored to underscreened communities in rural settings where access to care may be an issue as well. Next slide. So you'll see I've mentioned multi-level interventions several times, including with ACCESS, and I just wanted to pause and make sure we all know what that means, because it's something you'll hear people from our group talk about a lot. And it's actually pretty simple. We have spent decades doing interventions with patients and trying to get patients to somehow improve their care and make sure they get better care. And that's had some success, but it's our position that understanding what goes on around the patient and their clinician is equally important and perhaps more important than just focusing solely on the patient. So you'll see a lot of emphasis in our work on this multi-level approach. And so some of those studies I just mentioned are working with the community and with community-based clinical settings to wrap around the patient, support around the patient. And that is a very common thing we do, is ask people to do those kinds of studies. And as you all know, there are empirical questions one can answer about the various levels. So I just wanted to make sure everybody kind of understands that, what for us is a foundational principle. Next slide. This is our other big moonshot effort, which is to improve symptom control. So that means people who have cancer, because of their cancer or their treatment, will sometimes have very long-standing symptoms. hearing loss would be a dramatic one, peripheral neuropathy, fatigue. There's a variety of things that can carry on for quite some time or for the rest of a person's life. And so 2 of our 3 grantees here are focused on rural settings. The first one, in many ways, is trying to bring the Dana-Farber, Dartmouth College, very sophisticated academic medical center reporting systems and take them out to small rural and community cancer centers. So this is really focused a lot on doing systematic quality of life and symptom assessments and feeding that information back to clinicians. And so trying to figure out how to take something you can do in a single location academic medical center and roll it out to the community and to a different kind of population is very interesting. And so both of these 2 projects are pretty early on, that we don't have results yet, but I think very important. And I'll note that these are examples of efforts that did not specifically ask for rural applications, but got applications with a rural focus that were well received by reviewers. And I think it speaks to the recognition of these issues. Next slide, please. I'm just going to quickly mention this. These are administrative supplements to grants. It's a way, again, we build a little capacity. Somebody has a grant, we give them a little extra money to do something that they would like to do but don't have the funds to do. And this is one of the ways, between these 6 grants, we touch on almost that whole cancer continuum. Next slide. So this is a request for applications, also known as an RFA. And for those of you who may be less familiar with the NIH, that means we have set aside money. We're asking people to send in applications for that specific pot of money. And so this was an RFA that came out of our group that was specifically interested in improving the quality of cancer care in rural areas, specifically low income and underserved populations. And there was an intervention required, and there was a preference for multi-level interventions. And you'll see here that these are the 4 awards that were made, 1 for financial navigation, a very interesting one looking at offering palliative care through community health workers. You may know palliative care is something that has mixed receptivity in various communities. And so seeing if you can work in the community to increase access and willingness to participate. Telemonitoring is similar to the impact grants I talked about. And then telehealth access to molecular tumor boards and supportive care. I'm going to come back to telehealth at the end of my presentation. Next slide. And Jennifer, I know I'm at 12:40, so I'm going to have to go a little faster here. I've been telling too many stories. This is actually an active RFA that might be of interest to you. They are looking for applications to address modifiable risk factors. And if you look at the next slide, this is the list of modifiable risk factors they're interested in, all of which have special play out in special ways in rural settings. So I don't know if this is anything anybody in your group would be interested in, but clearly these are activities that involve working with healthy populations in primary care. And I know Dr. Stein has some HPV vaccination activities going on that maybe he can tell us about briefly when I'm done. Next slide. Okay, so here are a couple of newer things that we're doing. Oh, next slide. Again, supplements for the NCI designated cancer centers. These are coming up. May 21st is the deadline. But this is really about trying to reach out to clinics where there is persistent poverty and really start to implement some cancer control programs that would build capacity and facilitate future research. And again, this is really about getting the cancer centers out of their academic settings and into the community. So Dartmouth Cancer Center would be a potential contact if somebody wanted to apply for something like this or be part of an application, I should say. Next slide, please. Telehealth is obviously a huge issue. It was a huge question before COVID, not huge, but it was on our minds before COVID. With COVID, it has really sprung to the forefront. People had to do it. There was no choice, but I think our group feels like there's a lot we don't know about telehealth, and we know it's not a perfect solution for every problem. So we put out what's called a request for information, an RFI, to get a sense from the community of where they are in terms of delivering care by telehealth and doing research on telehealth. And obviously, these are some of the people who may benefit from telehealth. People with time constraints, people in rural areas, specialty care where it may be more rare in certain communities or the access may be more difficult. Next slide, please. And then there are a variety of barriers, lack of broadband, lack of a compatible digital device, limited digital literacy, and of course, much as we say rural areas will benefit from telehealth, rural areas also have broadband challenges, and NCI is actually working with the FCC on an initiative to address this, but slow going there, I'm afraid. And so, next slide. We have actually just this past week released another request for applications, and we are going to be funding centers that will be doing rapid cycle research and hopefully a larger intervention to really try to understand telehealth better and understand when is telehealth, when does it work well, when doesn't it work well, what makes it sustainable, what kinds of resources do people need, what kind of patients, really a very broad call for ideas. A center provides a chunk of funding that really lets people do a lot of things. And in this funding, we have specifically called for each center to establish a clinical practice network. So we don't want this to be, it goes to the academic medical center and they build their own telehealth system. This is, you go out into the community and you work together to figure out what's going to work in our setting. And so these are due in July. We have an informational webinar coming up. I probably forgot to put our webpage at the end, but I can certainly send that to Jennifer or someone and have it disseminated. So we're very excited about this. Hopefully we can move quickly enough that we'll make a difference sooner rather than later. That's why we included a rapid cycle, which is unusual for NCI to give money to do research quickly and turn things around quickly. Next slide. Okay, next slide. Last thing I wanted to comment on is the Silver Tsunami, is what my colleagues call it. And this is the growth of cancer survivors in the United States and combined with the growth of aging populations in the United States. So this is the prevalence, this is how many cancer survivors you can expect to see projecting out to 2040 by their age. And the care of these folks can be quite complicated, but not complicated necessarily in a way that requires an oncologist. And there are a lot of questions about the role of primary care providers in survivorship care. Next slide, please. We don't have anything specifically going on in rural setting right now. I think, my colleagues who work in this area are really thinking about this first question. What is the role of primary care in long-term management of cancer survivors, particularly people with a low risk of recurrence? Certainly there's a belief that primary care doctors could do a fair amount of some of the follow-up, perhaps not all of it, but we really haven't figured that out. And we really, in my opinion, need research where primary care and oncology researchers work together to try to figure out how to make this work. And so while we don't have anything rural, this is a very active area. It's also an area where Congress is directing funding So I really encourage you, if you're interested in this area, to keep an eye out. You can certainly get in touch with me if you're interested, and I can connect you with folks working in these various areas. Next slide. So questions and discussions. Right before everybody got on, I mentioned to Dr. Sprague that I had taken BCSC out because I was afraid of running long. So Breast Cancer Surveillance Consortium is a long time supported NCI activity that includes Vermont. And Dr. Stein has given me some information about his program. So I don't know if either or both of you would like to comment very briefly so everyone's aware of your work.
This is Gary. I could sort of say a couple of things. There are really several groups that are really key in terms of tying rural Northern New England together, and that's Vermont, Maine, and New Hampshire. And one is the Northern New England Clinical and Translational Research Network, and that's an NIH-funded program which really deals with the challenges of rurality and rural health, and that ties together these rural populations. It tries not to deal with rurality versus neo-metro, but really tries to deal with the various dimensions of rurality, because one size doesn't fit all. So we're trying to understand some of the shared and common challenges. The second is that the oldest practice-based research network, this addresses the primary care issue, is what was originally the Dartmouth co-op. It's now the Northern England co-op practice-based research network. And here the aspirational piece is to be able to provide in a rural primary care practice the ability to be able to support some of the, not just survivorship care, which is key, but some of the clinical trials that are going to have less adverse effects. So you don't have to travel to Burlington to the cancer center here, or to West Lebanon, New Hampshire, or to Portland, Maine. Is there recognition for it? Well, I've had Doug Lowy here several times, and actually it was Doug Lowy's suggestion to put together an HPV initiative that you're referring to. And that is a program where we're trying to use peer-based persuasion, actually through performance-based interventions for the 13 to 17-year-olds to be able to go ahead and to convince their peers that it's cool to go ahead and to be vaccinated for HPV, and to be able to convince their parents that this is something which is what you would really want your child to have. And the Dartmouth group has been utilizing a media-based intervention, and the co-op is looking now at the 18 to 45-year-olds, and they're doing it through a somewhat different approach, because they feel that the adults are going to respond more to a shared decision-making, type of intervention. Joe Biden spent a day here, actually, when he was vice president, just after he had announced the Moonshot Initiative, and he's been a strong advocate of that program. And Bob Croy was here twice, actually, and he was the one who went ahead and led us to you, and we're delighted that you've accepted. So those are some of the initiatives. But I want Brian.
And for those of you, I'm sorry to interrupt. For those of you who don't know, Doug Lowy is a deputy director of the NCI. He's been acting director twice, and he's one of the inventors, more or less, of the HPV vaccine. This is a hugely important area, and we're very lucky to have a basic scientist like Dr. Lowy who also understands public health. He's been a great advocate and friend to us in cancer control.
And an incredible human being, as well. I mean, I'll give you one little anecdote. I mean, recently one of the medical students wanted to develop a project, and he spent a Sunday with her a few weeks ago to go ahead and to give her some good reinforcement in terms of what to cover. But I'd like Brian to explain the program that he's been instrumental in developing and expanding, because that has not just been very important in terms of the patient, but I think it's been incredibly important in terms of providing a resource for investigation.
Right, thanks. Yeah, so Anne mentioned the Breast Cancer Surveillance Consortium, and this is a NCI-funded network of breast imaging registries, essentially, around the United States. There's 6 different sites, and we have one of those sites here in Vermont, and we have a statewide mammography registry where we collect data from about the 15 facilities around the state that do breast imaging and radiology departments. And our current aims are not focused on urban-rural disparities, but we've managed to get in a fair amount of work, particularly in terms of access to imaging technologies and access to standard of care, biopsy techniques, and diagnostic workup following abnormal screens. We have an R01 pending, and I'm not sure if you're aware, Christoph Lee out at University of Washington has one that scored a 3rd percentile that's focused on disparities in the diagnostic workup following abnormal screens. So we're hoping that'll take off. But I do think it's, hearing your talk, Anne, and thinking about it, it has a enormous potential for investigating issues in rural health. It's 90% non-academic sites, lots of locations like here in Vermont and New Hampshire and North Carolina with that serve rural populations. So certainly, as Gary is saying, a resource. And this is something that's been going on. Anne mentioned, 20 years now, 25 years. So we have a huge amount of longitudinal data, rich data on patients with long-term outcomes and various steps.
Have, I can't remember if North Carolina expanded Medicaid or not, but anyway,
right. Yeah,
you should think about it. And again, we're not necessarily interested in urban versus rural. That's interesting, but if you look at a lot of what I presented, it's also looking specifically at rural because we understand, as Dr. Stein said, not all rural is the same, and comparing rural and urban is not necessarily the most productive thing. But yeah, as I told you, Brian, I was a little surprised when I did my PubMed search. I'm like, they're not doing anything rural.
Right. Yeah. Doing? And it's interesting, we're putting in our renewal, which is really focused on racial disparities. So it continues to kind of to be an untapped potential, I think.
Well, keep your eye out for an administrative supplement, I think.
Yeah, for sure.
I have a question, and I think one of the challenges that we are going to be confronted with as we emerge from COVID is really catching up on screening, catching up on treatment. And can you give us a little insight into some of the ways that NCI is thinking in terms of being able to support those initiatives? And by the way, I should mention the Clinical and Translational Research Network. One of my partners is Scott Remick. Okay, so I know Scott well, and Scott was in West Virginia before he came back to New England.
Yeah, so I'll have to say I haven't heard a lot about what NCI intends to do. We certainly have our director expressing a lot of concern publicly about delays in diagnosis and treatment. It's a good question. It's not one I've really thought of. We see our role as research and generating evidence and not necessarily addressing those kinds of issues, but it is something I can't say I've heard anybody. I'm sitting here running through all the different pieces of information, and I don't know that we've talked about it. I will say, I think there's going to be an interesting natural experiment here. And this is a little heretical for me to say, but we know we're overdiagnosing cancer. And so it's not so simple to say, oh, we quit screening and we're going to miss this many cancers. Some of those cancers you so-called miss may have been overdiagnosed cancers. And so I think it's going to be really interesting to see what plays out over the next 5 years. But I can't say, I'll go back and ask, but I can't say that I've heard anybody talking about what NCI is going to do to get caught up. I will tell you, all of our grants are behind. Everybody is behind in their work, and we're struggling with what are we even going to do with that? Are we just going to give everybody an extra year? They're going to need more money. Where's the money going to come from? I think there's a lot to figure out. And as you can see, our group has actually probably been more productive during telework than we were in person. Certainly no drop off. And so, but we have a lot to figure out in terms of how we're going to manage people's grants. We've been extremely flexible and will continue to be, but it's been devastating to some people's research programs. So yeah, that's a great question. What are we going to do to catch up for the patient care?
I mean, I was looking at some of the numbers, and one regional center here is 3,000 colonoscopies behind, for instance.
Yeah.
I mean, so we're not looking at small numbers, but we're also very much involved in the question of overdiagnosis and overtreatment. And Brian, Janet Stein, Don Weaver from pathology here, in collaboration with a series of institutions, we're part of one of the consortium grants to actually address that question. And one of the resources we have here is a tissue bank that has incredible collections of early stage cancers, and that's been a national resource. And we're doing everything from molecular biomarkers to actually going ahead and looking at the imaging pieces. So it's
I got to know Dr. Weaver. At the same time I had met Brian. I think he's terrific. So I'm glad to hear that work has continued. That is a really neat resource.
I disagree with you. He's more than terrific. He walks on water, actually in the summer, not just in the winter.
Any other questions, comments?
I want to express appreciation for sure. I mean, because what you've said has been very informative, not just for the physicians who are on screen, but for the scientists, the physician investigators, and another part of your audience is a lot of students. So I think you've also shown folks exactly what can be done.
I have a question, and this is Marie Wood, and we've met in another.
Yeah, I was going to say another person I know. How are you?
I'm good. I'm good. It's cold here though, but I just saw that my daughter is knee deep in snow, so I don't feel bad. I'm interested, especially in a rural population, of thinking about how we can better interact with our primary care colleagues, and wonder, I know we don't have a lot of time, and maybe this is a bigger conversation, because I think we need to do this within the NCOR mechanism, as you spoke about, but we also need to do this in the regional work that we do. Any insight into mechanisms or way of thinking?
It's really tough, and I'll confess I have avoided that question because it feels overwhelming to me how to make those connections. And in NCOR, it's so oncology focused, and I'm interested in care delivery systems. And really, they're separate systems in many ways. What I will say to you is that our colleagues, my NCOR colleagues in the Division of Cancer Prevention, actually have an initiative going on right now where they're trying to look at this. And the person that leads that actually is a Public Health Service Commissioned Corps member who's at the border right now, been deployed to the border to work with some of the kids. But Marie, I'll make a note to myself. I think what I'd like to do is connect you with Bernard Parker. And
I was on that initiative.
Yeah.
I just thought you might have an idea coming from a different angle. It's tough.
Yeah, and I will tell you also that our work creates a little conflict with AHRQ, Agency for Healthcare Research and Quality. They really see, I shouldn't say this, it appears to me that they see primary care as their purview, and they get a little anxious when we start tromping around in their purview. And so that's also created a little hesitancy. I think if it comes from the research community, it's a little easier for us. But I think, one thing I would definitely say to you is start small. In the NCORs, we need to find one or two NCORs who can do it and figure out what works and what doesn't.
I think that's a great idea.
Yeah. So yeah,
Thanks.
follow up with Bernard in a couple weeks. He should
Yeah.
be back in a couple weeks.
Oh,
Um,
gotcha. Thanks for that
yeah.
information.
Yeah,
Thank you. And thanks. This was a
Well-
great talk.
good, thank you.
Well,
I think we're at time, yes?
Yeah, thank you very much, Dr. Geiger, for joining us and for your insights. That was a really great conversation.
Great, thank you all. Have a good weekend.
You too, and thanks
Take care.
again.
Thank you, Anne. Great to see you.
Good to see you.